Now, Fish, it's all yours.
Okay, thank you, Ibrick, and welcome to our WMS Student Interest Group lecture series. I'm just going to start sharing my screen, and Ibrick, you're probably going to have to look at the chat from now.
I will.
So this is me. I'm presently working as a paramedic with the Canadian Ambulance. I also am a diving instructor, and I have my dive shop in Goa. I'm a form candidate, also working on my DHS with Corom. Presently, also working on my critical care paramedic with University of Florida at Gainesville. I also dabble in a little bit of teaching otherwise in EMS. And like I said, I own a dive shop in Goa. Today's talk is going to be on parasites and protozoal infections in the traveler. And all of these talks that you'll attend, if you're students, you can claim WMS form credit. You need to attend the full talk though. So scope for today is going to be parasites, routes of transmission, common parasitic infections, prevention, management and treatment, and a little bit of remote diagnosis. So the word parasite actually comes from the Greek word parasitos, which means to dine at the table of another. And it's basically any organism that's living in or on a host and receives its food from the host. Also, some of them need specific hosts for their life cycle development, and we'll go about that as we go ahead further. Three main disease-causing parasites in human beings. I'm not covering all the disease-causing parasites, but we're looking at protozoans, which are like malarias, helminth, which are worms, and ectoparasites, which are external and like lice and scabies. So, like I said, you have obligatory parasites which are forced to reside in a host, which definitely need the host for life cycle development and sexual development. Then you have facultative parasites, which can either reside in a host or a medium. You have some of them living in water bodies or external uh, features, and they don't need a living host for their development. You have aberrant parasites as well, such as the Toxoplasma gondii, which is infectious but does not need the host for its life cycle. Of I've just given a little bit of examples below. And Toxoplasma gondii generally comes from cats. It's in cats, it is transmitted from the mother to the child or to the kitten. And in human beings, it can come in as a non obligatory parasite and then cause toxoplasma infection. Now, in the host, you have various different types of hosts where it primarily depends upon the development phase of uh, the parasite. You have intermediate, which is they're still in the larval or asexual phase. Definite host is where the sexual maturity of the parasite is reached. And that's where you have quite a bit of infection in human beings as well. Accidental uh, hosts are where there is no further development of the uh, parasite, but it can infect the host. Paratenic is where they're not involved in the life cycle at all, but they can be can be uh, carriers and can be vectors. Reservoirs are again they act as a temporary host and mode of transmission, but do not cause any infection, and there's no development happening. We move on to parasites in specific protozoa. Again, a Greek name, which was taken by German zoologist George August Goldfluss, and he kind of coined this name in 1818. He published a book on modern protozoa, and Basically, it's a unicellular animal capable of using human hosts for life cycle and for transmission. Transmission in most cases is via food, water, and fecal oral route. Some cases vector-borne as well, like Plasmodium. And the classification for protozoa is based on their movement types. You have Sarcodinia, which is amoeba, uh, Mastigophora, which is flagellates, Celiophora, which are ciliates, and Sporozoa, which are non-motile. Helminths, sorry, comes again from the Greek word of parasitic worm, helmin. They're multicellular invertebrates, and they can be elongated, flattened, or round bodies. The adult stage, they're visible to the naked eye, pretty much, again, based on their morphology. You have platyhelminths, which are flukes or tapeworms, nematodes, which are round, cylindrical worms, and acanthocephalans, which are thorny-headed worms. Basically, most of them are the thorny-headed worms or the acanthocephalans are the ones which are not known to cause infections, but they do reside in human beings' GI tracts. They have been known to reside in GI tracts. We come to ectoparasites or the external parasites, which generally infect and infest on superficial layers of the skin. They are associated with a significant epidemial morbidity in many cases. Ticks, fleas, parasitic flies, and mites are common. And this is a little scabies mite. So, coming to routes of transmission, water being one of the key routes of transmission, as it is important for life, both human and parasitic. Blood transfusion is known to carry both spores, um, juveniles, as well as larval phases and full amoeba and parasitic animals, organisms. Sorry, it's also through food. When you have infected undercooked meat or raw meat, you can get uh, eggs and larval stages of certain uh, parasites. Also, plants where animals which have been infected have passed stool over, and the eggs are then present on the plant material, which we then consume as food or salad. Contact between individuals, especially when you talk about uh, the ectoparasites, and primarily you find lice and scabies being very common but in contact. So there are two types, which is horizontal and vertical. Horizontal being between species and medium, as direct from the source to host, or indirect, which is multiple hosts, including malaria. Vertical is from the mother to offspring. I'm going to cover these three common parasitic infections. There are way too many parasitic infections to cover in 1 hour and do some kind of justice to it. These are some pretty images. I'm a glutton for images taken with microscopes, so it looks pretty nice. So coming to malaria, malaria is probably the most prevalent infectious disease, with about uh, 627,000 deaths in 2022, and it's widespread globally across 80 countries, and it's caused by 5 different subspecies of Plasmodium. Some of them are uh, now getting chemically resistive to prophylaxis, as well as drugs used for cure. Malaria requires 2 hosts for its life cycles, both mosquitoes and human. And interestingly, sickle cell trait is protective against Plasmodium falciparum. This is an image of the uh, spread of malaria. And as you can see, it's pretty widespread, mainly in Africa, and a large amount of infant and pediatric deaths occur in Africa. It's the life cycle of the malaria parasite. As you can see, it requires the mosquito for its sporogenic stage and human being for both the exoerythetic and the erythrotic sites, where it undergoes asexual reproduction and sexual reproduction to produce further plasmodium. Again, a view of the life cycle. So malaria's transmission is via mosquito bite or blood transfusion of unscreened blood. It has been known to infect people from blood transfusion after the blood donor was infected about 7 years prior and had malaria. The receiver got malaria about 6 years after being transfused. Case study was pretty interesting for me to read, and apparently the uh, parasite can stay in the blood for a long period of time without causing any symptoms. But most travelers do get malaria, and the incubation period is between 7 to 30 days. So it's mostly seen after return from travel. Uh, I mean, I said most travelers do get malaria. I mean, most travelers who get malaria, you notice them after the return from travel. So all febrile patients with a recent history of travel, formal travel, should be screened for malaria, and do not rely on any prophylaxis for any kind of immunity or non-malaria fever. So the malaria parasite multiplies in the human liver and infects the RBCs, where they further undergo more asexual reproduction and sexual reproduction. The cause of primary jaundice and hepatomegaly and splenomegaly is from the rupture of the RBCs and hepatocytes. Something interesting is that Plasmodium falciparum can cause microvascular emboli because there's a certain protein that they can put onto the surface of the RBC infected RBCs, which then causes an adhesive phenotype of RBCs, causing them to adhere and clump together, as well as adhere to the vascular endothelial cells, which results in tissue hypoxia, cerebral symptoms, and even pulmonary edema and pulmonary embolisms. So malaria should always be in the differential diagnosis for any patient with fever, with recent travel history to a malaria endemic area, or any patient who has fever in a malaria endemic area. The primary symptoms can be fever, which is either intermittent every 2 days or every 3 days, or it could also be daily fevers, nightly fevers. We hear about nightly fevers and chills, body pain, nausea, vomiting, seizures, and they can also be altered mental status and short of breath in more complicated versions of malaria. A signs you will have would be they would be febrile, tachycardic. You'd notice jaundice, pallor, and diaphoresis. Also, in more complicated cases and more advanced cases, you will definitely notice splenomegaly, which is easy to see and feel. For labs, you would want to check the complete blood count to check for anemia, thrombocytopenia. Malaria parasite in blood is the gold standard through microscopy. And there are also rapid detection tests and PCRs. So malaria that has any of the points listed on this slide would be considered as a severe complicated case. Uncomplicated being where it's almost self-resolves. However, you still need to watch for anybody with malaria uh, diagnosis, confirmed malaria diagnosis. My mother actually got malaria 7 times in a period of about 2 years. Couple of times severe malaria, but she's still with us, so it's good. So malaria, I was going to cover uh, repellents, PPE in a separate slide, but I think each one needs, especially malaria, definitely needs its own. So commonly you have DEET, which can be used for children above 2 months and adults. oil of lemon eucalyptus, IR 3535, and picardin, which is also good for ticks and chiggers. Permethrin and mosquito nets with full sleeve shirts and long pants. Also, head nets can be used and are pretty commonly used in when you're in the bush and outside in the open. Malaria accommodation is also very key, especially specifically when you're in a malaria endemic region. And these accommodations can be tents, hard structured wood, or concrete. But you must make sure that they're insecticide treated, well sprayed. Make sure that there are screen windows and doors to prevent the mosquitoes from coming in. Use of ceiling fans where applicable, and try and remove all stagnant water sources from nearby, and specifically from sleeping areas and plants. Quite a few people like to keep uh, house plants, and house plants can be a source of uh, malaria, mosquitoes, and malaria larvae, mosquito larvae. So we now move to cysticercosis and teniasis. Cysticercosis is the disease due to the development of the larval form of Taenia solium, or the tapeworm, which is primarily from the pork tapeworm. Teniasis is the human infection of the adult tapeworm from Taenia solium, Taenia saginata, or asiatica, which are primarily pork and beef tapeworms. Again, worldwide distribution, pretty widespread across anywhere where you have pigs and cattle. The intermediate host for these is are pigs and cattle, and the definitive host is human beings. Uh, Transmission is both from fecal oral route and from ingesting infected meat, as the eggs uh, are passed from in feces, and then can be ingested from uh, water, food, just improper hygiene. Ingesting infected meat, the meat has to be properly cooked, and make sure that there is no infection if you do have the possibility of getting veterinarian checked meat. This is the life cycle for the Taenia solium. As you can see, it causes two different infections in human beings, with cysticercosis being the more dangerous one. So the ingestion of eggs or gravid proglottids, which is the segments of the worm, can cause the larva to then hatch in the intestine and migrate via the blood vessels to various tissues. If you see this image here on the bottom right, you notice that there's a little bit of an appendage attached to a small little balloon kind of structure. That's the uh, larval stage of the worm, and it can migrate to nerve tissue. Apparently, it has an affinity to worm tissue, nerve tissue and glial cells, which is a large leading cause for adult onset and acquired epilepsy in human beings. Diagnosis is via microscopy. Here are a couple of images of the larva in the brain and in the eye. Teniasis is from the adult worm, which is basically both uh, the Taenia solium and Taenia saginata. It's the life cycle of the worm. So interestingly, this is an infection of the human intestine by the adult tapeworm, and the eggs can survive for several days, about 7 to 10 days in the environment. Intermediate hosts are cattle, and in some cases humans as well. And the larvae and eggs are passed in stool. Often, you have sisters in the tissues where it's migrated, and especially when you're eating uh, animal meat, which is raw or undercooked. Tapeworm has been known to survive in human hosts for about 5 to 7 years, so they're pretty long lasting. The symptoms are pretty mild. You have pain in the abdomen. Passing of the proglottids is often noticed. Uh, Appendicitis or uh, I'm sorry, I'm getting a brain fog to pronounce this right now. Bile duct infection from the migrating proglottids and cystic sarcosis. Diagnosis again via microscopy and through microscopy of feces and also from endoscopy. Severe cases can cause nausea and vomiting, diarrhea, reduced nutrient absorption, and the specific treatment for both of these is depending upon the location of infection, symptoms, and severity. Some cases of cysticercosis have been known to self-resolve. Uh, Teniasis is treated with primary nematode medication, which is praziquantel and albendazole. Prevention is often the best, and it's easy to do via proper hygiene, hand washing, avoiding raw and improperly cooked meat. In the field, we definitely want to have proper sanitation and make sure that we have uh, good practices for our ablutions. Washing vegetables that may be soiled with animal stool if you're eating raw vegetables. Scabies, now coming to the ectoparasites, covering scabies, the infection of Sarcoptes scabi. It's an obligate burrowing parasite. Obligate means that it needs the human host for its life cycle. It lives in the stratum corneum and burrows underneath to create uh, its it's a burrows into it, and the female stays inside the burrow. The male enters the burrow and thereafter uh, mates with the female. The larvae form again, continue and keep infecting the skin. Transmission is both via physical contact and fomite, which basically means that surfaces that have been that have larvae or eggs or live scabies, mites can cause infection, cause transmission. Again, globally widespread. It has a delayed clinical presentation because once the scabies larva or scabies mite infests the human or animal, it then takes a few weeks for it to develop into a full-fledged presentation. To primarily have see it as erythematous papules, and crusted scabies can occur in immunocompromised individuals uh, and has been seen in people with HIV. Again, the life cycle. There's a couple of pictures of infantile scabies and crusted scabies. I wonder why it's called Norwegian scabies. Diagnosis again for scabies is both clinical and microscopic examination of burrow scrapings in the skin. You have to be careful about the burrow scrapings and make sure that when you are taking a sample, you do not cause any further damage or uh, take care that the mites do not get crushed, because then you're not going to be able to see identify the mites properly. Make sure you clinically examine for secondary bacterial infections, and the first line of treatment is permethrin, which is a topical application. Ivermectin is definitely used for patients who do not respond to the topical treatment, but is a second line of treatment. So the prevention for scabies is to avoid contact with infected individuals. Make sure that you treat the entire family or entire people who've been contacted, the people in contact, and institutions at the same time, preferably rapidly. Bedding and clothing during the infective period should be thoroughly washed in hot water and hot dryers, or washed in hot water, boiled, disinfected and sealed in plastic bags for about 2 to 3 weeks, because the scabies larva and the scabies mite does not live more than 3 to 4 weeks. So if you have the clothing, you can seal them, probably use solar disinfection as well by keeping them out in the hot sun. Clean and disinfect rooms, including vacuum. If you don't have vacuum, make sure you clean it as thoroughly as possible. So prevention of all parasitic infections. Primarily, remember we did a pre-travel consultation discussion and talk on the student interest group earlier. So it's important to educate your traveler. Make sure that you get a full history. Make sure that you get the patient's uh, demographics, do a full risk assessment of where they're going, what location, what's the prevalence of any diseases. Water treatment has to be taught to them as well in case they're not regular season travelers. You can educate them on the various types of water treatments available. Insect repellents, PPE, and proper accommodation when they are in the wild. Chemoprophylactics, and I've got another slide specifically for chemoprophylactics, and any special considerations based on the demographic of the patient, the age, sex, pregnancy or non-pregnancy, and so on and so forth, and any, of course, immunocompromised individuals. So there are certain considerations which you must have for chemoprophylactics. Primarily look for areas and make sure that your location is the traveler's location is well understood, because there are certain areas where there is already chemoprophylactic drug resistance, especially in the malaria parasites. Make sure you have a full traveler's medical history of pre and post and future travels, and also understand that if they have been traveling earlier, they would know what is a good prophylactic for them. Make sure that they make sure to understand whether they're actually compliant with any medical therapy and prophylactics. For any person going to a malarial region, you definitely want to do G6 PD testing to make sure that they can take certain malarial prophylactics such as chloroquine, and also certain other drugs, antibiotics, which may be available only locally. Uh, the traveler's budget, location, and duration of travel is important, depending upon whether they can actually carry the drugs or will need to buy them. Also, logistics for proper, make sure that they have the proper dose, depending upon whether they are compliant, whether they are willing to take the time to understand and follow up on their prophylactics. I already did mention make sure that they have adequate drugs or ensure that there is local availability of drugs. So treatment for any parasitic infection is the same as any infection or any disease. You would determine the severity of infection and disease progression, also the location of infection, get the patient's pertinent medical history and past medical history, consider any drug resistance and chemoprophylaxis that they may have taken. Always use the best available resource to you, whether it is the CDC, the WHO, or your local health center. Oftentimes, local health centers do have great information which is pertinent to the specific endemic illnesses. Also ensure optimum nutrition and safety of the patient, especially when you're in the wild where you have a prolonged extraction or a prolonged, basically prolonged field care. Track the patient for relapses. Like I said, malaria can stay in for years. Patients could have relapses. It's quite well known. Also for any infection by worms or ectoparasites, keep a watch and see whether it's completely cleared or there are flare-ups that happen regionally. So coming to field laboratory classification, with today's new cameras on cell phones, smaller equipment that you can carry, and lighter packs, field laboratory classification is really important for any field medic, especially if you're out in the wilderness and traveling in resource limited areas. This is a video of, there's no voice here, but it shows how a cell phone has been used with an attachment to become a clinical laboratory in the field. We do have a video here. Once I'm going to share the QR code for the video and the link, which is basically our college. ABRIC is giving a talk on field laboratory classification. It's a nice half an hour video which you can watch once we are done with this talk. A lot of RDTs can be carried, as well as certain in the field laboratory classification video. ABRIC definitely covers a lot of field medicine and field laboratory. So you bear in mind that you can actually have a full-fledged laboratory, and you should have a full-fledged laboratory when you're in the field in today's day and age. Here's the link and the QR code. You can scan it and it'll take you straight to the video. I'm going to keep about a few minutes. You could maybe even take a screenshot. So to summarize, parasitic infections can be fatal. Definitely do a full pre-travel risk for your travelers as well as for yourself. If you are going, make sure you do a full screening. Prevention can just be clothing, also accommodation and chemical. Some parasitic infections are reportable, like malaria is reportable in the US. Depending upon the country that you are in, please make sure that you do report any parasitic infections that are reportable. We also spoke about simple diagnostic tools, and technology allows us for a wide variety of diagnostic tools nowadays. Treat patients always with evidence-based medicine, and make sure you track and follow up to cater for incubation periods. Like malaria is 3 to 7 days, 7 to 30 days, and other infections can even be longer. These are most of my references. There are some which I haven't put in, but these are primarily the ones which I used. Any questions? Please send it to us at education@corom.edu.mt. As always, Corom does have a number of courses that are valid for the field medic, and some of them also give WMS form credits. So please feel free to take a look at our website and enroll in any of them if you feel interested. I'm done with my slides. Just gonna stop sharing now. And any questions? I didn't expect it to go so fast. QR link. Thank you, Jody, for the Norwegian scabies ethnology.
I just put a link on the chat on London School of Hygiene's Tropical Medicine's Diploma of Tropical Nursing. And I put it there because it's probably the best option for paramedics and nurses to get tropical medicine learning. It's not part of WMUS, but it definitely covers the tropical diseases that you were shown this evening, and it's online, and a number of our faculty have taken it, and I'm biased because I'm a lecturer for the Diploma of Tropical Nursing, but it's a good option for you guys to look at. Visher, is a question about, is there a patient population progresses from regular malaria to severe malaria? So what age and comorbidities is going to cause cerebral malaria, Vish?
Mostly when you have a patient population, that you're going to look for nutritional issues, you're going to look for any prior malaria that they've had, people who have anemia or any kind of blood, uh, what should I say, low count on red blood cells, because red blood cells and any people with liver cirrhosis or any liver damage, it's going to go further, because those are comorbidities which you want to look at. Any Primarily think about it this way: the malarial parasites affect the hepatocytes, the spleen, and the red blood cells. So anyone with a comorbidity that affects any of those is going to be more susceptible to going into severe malaria. Also, age, definitely younger children, pediatrics have lesser blood volume and most of their a lesser number of erythrocytes. So again, they are more susceptible to developing severe malaria.
This is one reason we focus heavily on falciparum malaria, because that has the highest risk of getting into cerebral malaria and severe malaria. So if you want to choose one malaria of the 5 malarias to focus on, falciparum is definitely the one you want to start with. Vivax is by far the most common and reoccurring, but falciparum is what kills.
Right, and falciparum primarily being the one which does have the ability to change the erythrocyte to the adhesive phenotype, which then allows clumping and causes microemboli and tissue hypoxia, which is the main reason for cerebral malaria.
Vish, you raised a good point earlier about the traveller and monitoring the traveller. You don't have to be working in these environments to experience people with malaria. For myself, the last time I had a malaria patient, in inverted commas, was on a North Sea oil rig. And it was actually a Nigerian employee of Shell that ended up in the middle of the North Sea and developed his malaria symptoms there. So again, it's not just limited to those places where you get malaria. It could be any place in the world where you get a malaria patient.
Right, there's about 2,000 cases every year in the US, and US is not, apart from the southern US, is not really well, what I would say, a malaria endemic region. But you do get people, especially travelers, and like you said, people coming from regions where malaria could have been picked up. I was amazed as to how malaria can stay on for 6 to 7 years in a patient and then be transferred via blood transfusion, which is why the US now does not permit people with uh, coming in from malaria regions. They have to wait for at least 3 years to be able to donate blood. And if they travel to a malaria endemic region, they have to wait for 3 months before they can donate blood.
And just a quick question, Vish, is there any one malaria prophylaxis that you might recommend?
Malaria prophylaxis, I mean, you have quinine, you have quite a few of them outside. I don't remember the names off the top of my head straight off. It's just my mind is just going off with pronunciations today. But yeah, the thing is, for malaria, because of chemoprophylactic resistance, you definitely want to make sure that the region that the person is going, or you're treating, you make sure that there is no resistance that has been documented before prescribing any chemoprophylactic, because you could give them something which which the malaria over there, the parasites over there are resistive to, and like Plasmodium falciparum and vivax, because they're the most common ones, have been very have become very resistant to quinine, for example, chloroquine quine for the first part. And like I said, I'm just, my head is just not pronouncing words today. But yeah, so we want to be careful about the resistance that has been developed before prescribing anything.
Thanks.
Doxycycline would be used for the treatment rather than as a prophylactic before getting malaria.
There, there are quite a few people that will give doxy for prophylaxis instead of Malarone. So it is out there, even though Malarone has less side effects. And your statement was about being very careful to make sure you don't have drug resistant. Last time I was in Thailand, they had a law that was immediate arresting if you have anti-malarials that wasn't prescribed to you. That's an arrestable defense because they have such a huge problem with anti-malarial resistance. So make sure when you go to your whatever country you're going to, take a look at the whatever country you're from that has a State Department or Ministry of Foreign Affairs that will tell you the current status of the antimalarials, because you got definitely need to be careful. A couple statements about doxy. One of the problems with doxy is you do have to take it for 7 days before your deployment and 4 weeks after. So that is a longer duration, and then adherence is going to be a problem if people in your safari or whatever you're going on, if they're not extremely consistent with their anti-malarials, it will be a problem. But so doxy is one problem of that is it just you take it for much longer. The nice thing about doxy, it also hits some other wee beasties, some other trot med diseases at the same time. But Malarone is going to be a better option. Hydroxychloroquine is an option as well. Good questions.
My main thing has been just making sure that there's no resistance, and especially doxy being antibiotic as well. Just, I prefer to think about what we're going to do, and rather than just blindly prescribe any medication to somebody.
Correct me if I'm wrong, Vish, but don't we have a vaccine now for malaria? Or one of the variants of malaria?
You are definitely right. It was released in 2022. It's primarily being used on pediatrics right now, and it has clear testing, so it's being used especially in Africa. But they haven't. I don't think it exists yet for adults. I think it's still maybe in work in progress. But definitely, it has. There is a vaccine since 2022.
Yeah, the vaccine is called RTS-X, and it's only approved for pediatrics thus far.
Jody, I'll have to look for it. If you drop in an email at education@quorum. At our website, quorum.edu.mt, I'd be more than happy to find the paper and send it to you. It should be available online because I definitely found it through one of the more peer-reviewed journals. So
There's a question about the case study you referred to with the 7-year malaria, that within up to 7 years, there's a problem with blood transfusion, probably with Vivax. Do you have the PubMed link on that one, Vish?
I'm just going to look and see right now if I can find it. I'm using the same. Oops, I'm just looking through my history and just see if I can find it. I'll put the link right now if I can.
So adding to my comments of training, there, for those of you who are physicians or physicians in training, the Diploma of Tropical Medicine and Hygiene, or Tropical Medicine and Health, one of those two, is going to be the industry standard, the world standard for you to get prop med training. Getting DTMH after your name is a pretty profound marker for your level of understanding of tropical diseases. You can get them anywhere. There's 11 or 14 programs around the world that offer the DTMH, and we have a DTMH in the works that has been accredited, and we will be running it as soon as I can get enough of my faculty to put together the rest of the curriculum. And DTMH we have the only DTMH program that will accept non-doctors. All the other programs will never let you in unless you're a doctor. And we think that nurses and paramedics, and I'm biased, of course, should also have privy to this. But for those of you who are interested in tropical diseases, then you definitely need a DTMH after your name, or DTN, tropical nursing, if that's an option for you as well. So whilst Vish is looking up that link, if anyone has any questions about tropical diseases, or if any of you have a question about the college, now is a good time to do it. We can talk about other programs we're doing, or why we're here, or why we keep pushing the way we're pushing for excellence in austere environments. So just kind of an open session on anyone who has questions.
If anyone wants to come to Malta and join our remote EMT course, they're more than welcome.
Also, for those of you who have our field guide, we have quite a bit of information on tropical diseases in the TropMed section in the back. I think Jason has about 32 pages dedicated to tropical diseases. So that's available for you guys if you're members of the college, or if you want to get it, you can go to fieldguide@quorum.org. I can put that in there. That's the website. If you guys would like a tropical medicine field guide along with a whole bunch of other medical things.
Again, I'm biased, but the field guide is pretty intense. It's really good. It's a really good resource. So I just found a link to blood transfusions. It's not the one which I spoke about, but this one does have enough information to get you started on thinking about it. Prima facie, it says that Plasmodium falciparum, Vivax, and malaria can persist. Falciparum for 1 year after being cleared, Vivax for 3 years, and Plasmodium malaria has been known to remain a chronic infection at low density for decades. So like I said, I'm just reading through quickly in this article. There's a lot more out there, which I definitely will find that article and send it.
All right, we are at 50 minutes. I'm happy to stay on for a bit if anyone wants to have a chat, but we can officially stop the recording and end the